Dr. Ken Osborne. Dr. Osborne is the co-chair of SABCS. He is also the director of the Dan L. Duncan Cancer Center at Baylor College of Medicine. Dr. Osborne.
Thanks, Rachel. Welcome to the second, press briefing. And I think you're going to hear some exciting presentations today. I'm supposed to do my disclosures. I was on an advisory board earlier this year for Genentech to discuss the Affinity trial results and also AstraZeneca, and I was a consultant for Tolmar Pharmaceuticals, and I own stock in a company that I started 30 years ago called GeneTex that makes antibodies for diagnostics. Okay, our first speaker is going to be Peter Schmid, MD and PhD and Professor of Cancer Medicine at Barts Cancer Institute in London. And he's going to present the results of the Keynote-522 study of Pembrolizumab plus chemotherapy versus placebo plus chemotherapy as neoadjuvant treatment, followed by Pembrolizumab versus placebo as adjuvant treatment for early triple-negative breast cancer. Pathologic complete response in key subgroups. Peter.
Thank you very much. It's a pleasure to be here this morning and share these interesting data with you. As we're all aware, patients with triple-negative breast cancer who get neoadjuvant chemotherapy and achieve what we call a pathological complete response, which means the complete disappearance of the cancer prior to surgery, they have a sustained clinical benefit. There are meta-analysis data that show a strong link between PathCR and long-term outcome for long-term event-free survival with a hazard ratio of 0.24 and overall survival with a hazard ratio of 0.16. We know if you give neoadjuvant chemotherapy with anthracyclines and taxanes, the PathCR rates are around 40%. If you add in platinum, they're around 50 to 55%. And we had prior to this study smaller trials that demonstrated that if we add pembrolizumab or other checkpoint inhibitors to neoadjuvant chemotherapy, that the treatment is safe and show promising early activity in triple-negative breast cancer. So we designed a phase 3 trial, Keynote-522, in patients with operable triple-negative breast cancer with either T1C tumors and node-positive disease or T2 to T4 tumors, irrespective of the nodal status. Patients were randomized between pembrolizumab or placebo given in combination with 12 weeks of carboplatin paclitaxel chemotherapy, followed by 12 weeks of AC or EC chemotherapy. Patients then underwent surgery. And after surgery, they carried on with pembrolizumab or with placebo for a total of 1 year. The trial had two main primary endpoints, and at this point in time, we have mature data and definitive data for the first primary endpoint, PathCR, the complete disappearance of all cancer. We also have early data for event-free survival, but the follow-up is very short at this point in time. If you look at the definitive PathCR data based on 602 patients, it is a statistically significant and, in my opinion, meaningful difference in PathCR rates of 13.6% between the two groups, with 51.2% PathCR in patients receiving the controlled chemotherapy and 64.8% of patients receiving chemotherapy and pembrolizumab. With a short, and this is short from an adjuvant point of view, follow-up of only 15.5 months, we see a separation of the curves, but not statistically significant at this point in time, considering the pre-calculated p-value boundary of significance of 0.00051. We have an estimated difference in the estimated 18 months event-free survival rates of 19.3% to 85.3% in the placebo group. If you look at the benefit in terms of PathCR by different disease stages, and the trial included patients with stage 2 disease and stage 3 disease, as you can see consistently across all stages, there's a benefit from adding immune therapy to chemotherapy. But what is impressive, in my opinion, is looking at the right side of the slide where you see patients with stage 3A and stage 3B, in other words, higher risk cancers, where the delta, the difference in PathCR rates is around 25% for stage 3A and stage 3B patients. Obviously, in the control arm, because these are higher risk patients, we see that the PathCR rate is going down, but we maintain a high PathCR rate in patients with the addition of pembrolizumab. If you look at patients with and without lymph node involvement, again, lymph node involvement being associated with a higher risk, also associated with lower PathCR rates, we can see that there's a consistent benefit in patients who are on the left lymph node negative or on the right lymph node positive. But I would again like to point out that patients with higher risk disease have a difference of a benefit of 20.6% from the addition of pembrolizumab to chemotherapy. One of the key questions is, do all patients benefit equally from immune therapy? And one of the markers in metastatic disease that's linked with response is something called the PD-L1 status. Now, we checked this out in this trial using an assay called CPS, and patients who were defined as CPS less than 1 are PD-L1 negative. Patients who are more than CPS or CPS higher than 1 are PD-L1 positive. And as you can see on the left side of the slide, patients with PD-L1 negative tumors, as per this definition, have a similar benefit from the addition of immune therapy to chemotherapy compared to patients with PD-L1 positive patients. We also looked, because other studies showed if patients have a very high expression of PD-L1 and have very immunogenic tumors, they may have an even higher benefit of immune therapy. And we wondered whether most of the benefit was driven by this group. But as you can see, the absolute difference in the delta between chemotherapy and the combination is consistent whether we use a cutoff of 1, of 10, or 20. Of note, if you look at the group of patients with a CPS of 10, so more inflamed tumors, or CPS of 20, we saw a path CR rate of 78% and 81% in these patients, a path CR rate we have never seen in such an aggressive disease group. One of the questions that came up when we first discussed the trial results was the chemotherapy exposure possibly different and affected by the addition of immune therapy? And we saw that if you have very stringent definitions of what is full dose of chemotherapy, approximately 80% of patients in each arm had full exposure of chemotherapy. If we look at, and there's an exploratory analysis, if you look at the path CR rates in patients who had full exposure of chemotherapy or patients who had less than full exposure of chemotherapy, we again see the difference or the benefit from adding pembrolizumab is around 14% for full exposure, 15% for less than full exposure, meaning that the benefit from adding immune therapy is maintained even in those patients who, for whatever reason it was, received less than full exposures of chemotherapy. So our summary at this point in time is that the addition of pembrolizumab to neoadjuvant chemotherapy produces a significant and substantial benefit in path CR rates, and we see a larger magnitude of the PCR benefits versus chemotherapy alone in patients with higher stage disease, in this instance stage 3 disease, or node-positive disease. We also saw that the benefit of neoadjuvant chemotherapy and pembrolizumab on path CR was observed in patients who received less than the planned chemotherapy, although, of course, the absolute path CR rates were lower in those patients who received less than chemotherapy, and also irrespective of the PD-L1 threshold, the CPS threshold for the assay used in this trial. Neoadjuvant pembrolizumab and chemotherapy was associated with a higher rate of RCB01, data we'll show later this morning, and we'll see that immune-mediated adverse events were consistent with the known profiles of each regimen, and we didn't see any new safety concerns. We feel at this point in time that further follow-up is needed to confirm the EFS benefit, and we also need longer-term safety profile data. We also present in the future additional biomarker data, which I think will be helpful, including TILs and BRCA1 status. Thank you very much.
So Dr. Schmid's presentation is open for questions, and maybe I could start them. I was interested in the results in the node negative and node positive with Pembro. Looks like the complete response rate is similar, 60-something% in those groups. And does that pass CR rate include lymph node status?
It does. So the definition we had is for tumor and lymph nodes. We have two additional path CR definitions, one without TIS, carcinoma in situ, and one without lymph nodes, and the results are consistent in these subgroups. But yes, it does include lymph node status.
Thank you. Yes, microphone.
Sorry, Pam Harrison, Medscape. Could you comment on the significance of this particular immunotherapy being effective in both PD-L1 negative and PD-L1 positive cancers?
Yeah, this is a fantastic question and a really interesting results. As you know, in advanced disease, we see a clear difference between patients who have PD-L1 positive tumors and PD-L1 negative tumors in terms of the benefit from immune therapy. Now, we don't see this in early disease, and there are different hypotheses why this might be. My personal theory is the tumor plasticity, the dynamics in the tumor biology is very high in early disease. We know from old chemotherapy studies, if you start patients on chemotherapy, that 3 weeks after the start of chemotherapy, immune cells are getting into the cancer. And the theory could be that patients who had PD-L1 negative tumors before the start of therapy turn PD-L1 positive throughout the process of having chemotherapy, because there's more plasticity in the tumors. That gets lost over time, and we don't see this in advanced disease. Hence, the results in advanced disease, metastatic disease, in Passion 130, which we presented a year ago, show a difference between PD-L1 positive and negative patients. But in early disease, we don't see this.
Actually, hi, Neil Osterweil with Oncology Practice. I was going to ask you about Impression 130, and if I remember correctly, as you reported in Munich, that was only the benefit seen only in those PD-L1 positive patients, as you just mentioned.
That is correct, but that is a metastatic disease, and we know that the tumor don't change very much. If you give chemotherapy to patients with metastatic disease, we don't see that influx of immune cells. The immune system is less active at this point in time, and that's my personal interpretation at this point in time, why the PD-L1 status is so relevant in the metastatic setting and less relevant in early disease. Now, we also have to take into consideration that PD-L1 expression in breast cancer is linked with immune cells. So what we see, if the PD-L1 expression goes up, we have a group of tumors that have more immune cells in the cancer and therefore are more able to launch an immune response. And if you can imagine, if you have a tumor in the advanced setting that's no longer dynamic, where you can't get immune cells in there, the best checkpoint inhibitor in the world will not be able to can activate the immune cells, but if they're not there, they can't kill the cancer. Whereas in early disease, we activate the lymph cells, and they can still get into the cancer because there's more dynamics in there, and therefore help destroy the cancer cells.
Yeah, thank you.
Hi, Caroline Helwick, ASCO Post. I'm interested in the chemotherapy arm on the PD-L1 negative patients, because the response rate there was like 30%, and it was like 60% in the expressors. So why would the chemotherapy work differently?
Yeah, that's a good question. And again, it's a well-established observation. For example, the German Breast Group and other groups have described this over the last 10 years, that patients who have a lot of immune cells, who have TIL-high tumors, respond much better to chemotherapy than patients who have a low immune system. Now, as there's a link between TILs, or tumor-infiltrating lymphocytes, and PD-L1, we assume if patients have higher PD-L1 expression, they have more immune cells in there and therefore respond better to chemotherapy. So TILs are a prognostic factor in terms of response to chemotherapy in the control arm, but interestingly enough, not in the arm when we add immune therapy.
Interesting. Thank you.
Other questions? Thanks, Peter.
Thank you very much.
Okay.